Hi everyone, my name is James Dorroh and I'm a student at the University of Missouri School of Medicine in Columbia. Today I'll be presenting a case of pulmonary eosinophilia associated with vedolizumab therapy for ulcerative colitis. Pulmonary eosinophilia refers to a diverse group of lung diseases that are characterized by increased eosinophils in the blood, tissue, or bronchoalveolar lavage fluid, as well as radiographic evidence of pulmonary parenchymal disease. Pulmonary eosinophilia has numerous etiologies, including medication or toxin exposure. It is especially important to recognize medication-induced pulmonary eosinophilia because withdrawal of the offending agent is frequently associated with resolution of respiratory symptoms. Numerous medications have been associated with pulmonary eosinophilia, including NSAIDs, antimicrobials, and a variety of monoclonal antibody therapies. What's unique about this case is that we describe an association between pulmonary eosinophilia and vedolizumab, a monoclonal antibody used in the treatment of inflammatory bowel disease. To our knowledge, vedolizumab has not previously been reported as a potential cause of medication-induced pulmonary eosinophilia. Our case concerns a 52-year-old male with long-standing severe ulcerative colitis of nearly 20 years duration. He started taking vedolizumab for his UC after failing infliximab due to an anaphylactic reaction. 3 months after beginning vedolizumab, his UC symptoms were improving, but he began to experience respiratory symptoms that noticeably worsened following his vedolizumab infusions. 8 months after starting vedolizumab, he presented to our pulmonary clinic with a persistent severe cough, dyspnea, and hemoptysis. This patient was a lifetime non-smoker with no history of lung disease prior to the onset of these respiratory symptoms. On workup, he was found to have peripheral eosinophilia with an absolute eosinophil count of 700. His chest X-ray and CT both demonstrated bilateral tree and bud opacities consistent with an inflammatory or infectious etiology. Figure 1 demonstrates some examples, with the yellow arrows highlighting these opacities in the right lung. The patient underwent bronchoscopy, which revealed erythematous bronchial mucosa, as seen in Figure 2. Bronchoalveolar lavage fluid showed increased eosinophils at 5%. The patient's infectious workup was negative. His BAL fluid was negative for fungal antigens and acid-fast bacteria, and his sputum culture grew only normal respiratory flora. Pulmonary function testing demonstrated a moderate obstructive defect seen in the flow volume loop in Figure 3, and his FEV1 to FVC ratio was reduced at 59%. Based on these findings, a diagnosis of vedolizumab-induced pulmonary eosinophilia was made. The standard treatment for medication-induced pulmonary eosinophilia is centered on discontinuation of the offending agent. This patient, however, had initially achieved good control of his UC symptoms on vedolizumab and was reluctant to stop the medication. He was therefore treated with bronchodilators and anti-inflammatory medications, which did lead to improvement in his respiratory symptoms. Unfortunately, the patient subsequently missed some of his vedolizumab infusions and suffered a relapse of his ulcerative colitis. Vedolizumab was then discontinued, and the patient was transitioned to ustekinumab therapy. He subsequently reported no further respiratory symptoms and did not return to pulmonary clinic. An important consideration in this case is that eosinophilia is a potential feature of inflammatory bowel disease itself, and was in fact seen in this patient outside the context of his vedolizumab therapy. However, given his pulmonary workup and the temporal association of his respiratory symptoms with his vedolizumab therapy, vedolizumab use appears to be the most likely etiology of this patient's pulmonary eosinophilia. A key point from this case is to consider vedolizumab in addition to other monoclonal antibodies as potential precipitating agents for pulmonary eosinophilia. Additionally, once the diagnosis of medication-induced pulmonary eosinophilia is made, clinicians must weigh the risks and benefits of discontinuing an effective therapy versus continuing the drug and managing the patient's respiratory symptoms with bronchodilators and anti-inflammatories. This concludes my presentation. Thank you for your time and have an excellent day.